Hello and good afternoon, everyone. Thank you for joining us for today's webinar session. We had a delay on the price transparency mandate, but we now have a final rule that has been issued, and that will be the focus of today's 45-minute session. We do still have a few people, it looks like, that are signing in, so we'll give everybody about 30 seconds here to get settled in, and then we'll go ahead and get started. All right, we're going to go ahead and kick off today's session with just some brief introductions, and then we'll get into the price transparency final rule and things your organization should start doing, thinking about in 2020 to start preparing. So just some brief introductions. I'm Brad Josephson. I'm the Director of Marketing here at PMMC. I'm joined by Greg Kay, who is the Senior Vice President at PMMC. We're a fully integrated revenue cycle management platform. And we've been really focused on price transparency lately, obviously with what's going on with the mandate, and more importantly, the strategic things that healthcare providers need to really start thinking about and taking seriously in order to prepare for this new normal. So at this point, I'm going to turn it over to Greg to start reviewing some of the specifics of the final rule.
Great, thanks, Brad. Hello, everyone. We've been meeting like this for several months now, and as we know, the President's executive order a few months ago, back in June, required 5 departments to review current laws and regulations to specifically identify ways to improve transparency with pricing and quality data available to customers so that they would have an easier time in shopping and searching for pricing and quality data for healthcare services. This time last year, as you may recall, we were responding to the request from CMS to post a standard list of charges, and today the final rules are expanding on that requirement from last year. It's important to remember that this is an industry issue, being pricing transparency, that most have been embracing. I think nearly everyone agrees with the baseline premise that consumers should have a better understanding of the costs associated with their care. Obviously, many of you are in states that have pursued various models. From a recent PMMC conducted survey of hospital websites, we found that over 90% of hospital websites today provide consumers with a number to call in to get a quote. 13% we found actually already have a self-service estimate tool. And this is really what CMS is pushing the industry towards, and that's having an easier electronic means to shop and compare the cost of healthcare. And the intent is to really identify ways to bring down or bend the cost curve through engaging the patient and providing better comparative information to follow basic economic principles, if you will. So in July, when the draft rules were posted, CMS provided a comment period that ran through September 30th. And on the 27th, there were just over 1,000 comments that had been posted. And based upon our review at that time, about 90% of the comments were in favor of the requirement. But at the end of the day, by the time the comment period ended, there was a surge to just over 3,800 total comments, with healthcare providers really stepping up and providing detailed suggestions with how to make the process better and the need for more time to really implement the final rules. So I think most everyone celebrated when the final OPPS rules were released a few weeks back without the pricing transparency final rules. thinking that, well, maybe CMS has just kicked the can down the road for a significant period of time and it's not going to be something we need to deal with. But that was short-lived. As we now know, CMS released the final regulations for hospitals and the draft rules for health plans back on the 15th. And I think it's important to note that from the comments, CMS did incorporate many of the suggestions that were made during that comment period. Most importantly, they did make the decision to move the effective date back to January 1st, 2021. So, okay, Brad? So I did want to touch on real quick, Brad, if we can go back one slide.
Sure.
Okay, thanks. I did want to just touch on real quick before we sort of do a deeper dive into the final rules as they exist today. It's important to note, and I think everyone should be aware, that this week several healthcare organizations, some associations, as well as several hospitals, filed suit to block the implementation of the final rules. The legal action focused on two primary points. The first being the new rule creates an undue burden. And the second is it really undermines competition. In the long run, may actually increase price, not decrease price. I think it's safe to assume that this question around pricing transparency, these final rules, will ultimately end up being decided in court, and that will likely take a few years to actually work through the process. But it's likely not going to stop CMS from pursuing the implementation during that, the debate, if you will, the legal steps that are going to be underway. So it's something that we all need to recognize. This will be sort of battled in the court of law, but for the time being, these are the rules that we should be continuing to move forward with as they're stated today. Okay. So in the final rules that did come out, there were several key changes that CMS incorporated. There were several updates to definitions. They provided some clarification around the requirements for posting your list of standard charges. They've incorporated some new requirements and options for shoppable services. This is definitely an area CMS appeared to have listened and took to heart and incorporated some of the suggestions from the industry comments. They've also provided an outline for specific action steps for those that are not compliant. And as I noted a moment ago, they did move back the effective date from 1/1/2020 to 1/1/2021, which was obviously a big relief to everyone. So as it relates to definitions, CMS clarified the final in the final pricing rules which hospitals was this going to be applicable for, and it really now applies for all licensed hospitals. It excludes the VA and Indian health programs as they don't negotiate reimbursement, but all licensed hospitals will have to comply. The definition of standard charges has also been updated and will now be defined with really 5 different components. The first being gross charges for items and services reflected in the hospital CDM. They've added a new definition for cash price, and this change again appears to be tied back to the number of comments that healthcare providers offered up and made in reference to there often being potential confusion with having a cash price for patients that pay at time of service versus a negotiated rate for a payer. So obviously CMS appeared to have listened, acknowledged the concern, and really now is requiring it be listed as a standard item. The other area was the payer-specific negotiated charge. And here the basic CMS premise is that the negotiated charge or the allowable is provided to patients, consumers, after the service today, with it being listed in the second line on the EOB or remits. And it's their strong belief that if this is being provided to patients after the fact, then it's reasonable to provide it to patients before a service. Now, this requirement, being the list of payer-specific negotiated charges, is for all payers and all plans with a contractual discount arrangement. CMS did confirm it excludes Medicare and Medicaid, as these were not negotiated and they're already published today. Some organizations may want to list it, but it's not a requirement. Now, there have been some questions raised to CMS if there were volume thresholds to reduce the need to list all payers and all plans. And currently, the final rule requirement is that it should be for all contracted payers with a negotiated discount should be a part of that payer-specific negotiated charge. The last two items are what they refer to now, and these are new items, as the de-identified min and max. These are going to be two additional columns that list the lowest and the highest negotiated rate for each of the line item and services. So when you look across the payer-specific negotiated charge, the de-identified min negotiated charge and the de-identified max negotiated charge is going to be the high and low of that item 3, the payer-specific. So they want to make it easy for the patient to be able to see what the high and low was for that particular line across all payers. The other definition that they noted was for items and services. And the requirement in 2019, this past year, was for line-specific items and services. But as noted in the comment period, our negotiated rates are often for services that are packaged together. We don't negotiate a specific rate for each detailed charge item. So what CMS has done is they've expanded the definition to now include what they're describing as service packages. And as an example, would be an outpatient service, such as a surgical service, that may often have multiple charge code items under a surgical CPT code. Similarly, with inpatient charges being grouped to a DRG or an MS-DRG. So in addition to posting your basic CDM file with line-specific items and services, in January 1, 2021, you're also going to need to include standard service packages with the corresponding gross charge and the negotiated rate. And on a call earlier this week, on a CMS Learning Network call, they used as an example a scenario where an individual raised the point that they had per diem rates or a base DRG or MS-DRG relative value. And CMS noted that was the type of rate that they are looking for us to list as a part of that service package. So you will be listing that after you go through your CDM file, the other additional service packages by payer. So CMS did outline the fact that we will need to provide an updated standard charge file, what they referred to as a list of standard charges. And so for the file format you posted January 1 of this year, being 2019, you can use that same file format again for 2020. And as a reminder, you are required to update this file annually, at least annually, which means many of you will need to update that file if you haven't already, January 1 or as close to that as possible. And based upon market research that we've done, most hospitals only listed their CDM charge code line description and the charge dollar value. So again, you can do that again in 2020, but for for 1/1/2021, this is going to need to be expanded to include a more easily understood description, as CMS has defined it, related CPT HCPCS codes, as well as other codes, and they called out specifically NDC codes and volume amounts for a consumer to more clearly understand your charges. So on screen, here's an example file based upon our current understanding. So there's a description, there's the facility location, because it has to be facility specific, the CPT HCPCS code, and other related information such as the NDC code and volume. There'll be the gross charge, and with the gross charge for multi-facility organizations, I mentioned it's got to be facility specific, but also if you have tiered pricing, in other words, a different charge rate for different service settings, it should be listed alongside the related service location. This particular example, there is an inpatient gross charge column and an outpatient gross charge column. So if there are, as an example, high-tech imaging procedures where you've got a different rate in an outpatient clinic setting versus the hospital setting, you would need to have separate columns here. We've got listed the cash price, and then you're going to list the de-identified min and max, which will be the lowest and highest value across all payers, and there will be the negotiated charge for all payers with a discount. So if you've got 30 payer contracts with an average of 2 plans per payer, you're going to end up having a file with 60 plus negotiated charge columns in addition to the columns listed here. Now, as it relates to service packages, CMS has shared that these can be listed in the same worksheet or under a separate tab within the file. So as an example, the inpatient DRG or MSDRG tab with the various negotiated rates could be listed at the bottom of this particular file, or it could be included in a separate tab within that particular file. Now, the second file requirement that CMS has offered up is the list of shoppable services. And based on comments from the industry, the final rules now provide really 2 different options: a comprehensive machine-readable file and a computer or commercial, if you will, consumer-friendly patient estimation tool. And CMS has acknowledged that many hospitals do have self-service estimate tools that allow patients to create an estimate of their cost prior to a service. And in their final rules, those tools will meet the mandate requirement, and they've offered up and stated in multiple places that there's a lot of flexibility that they're going to be providing to those organizations that have estimation tools. The bottom line is they recognize that consumers want to understand their cost, and these tools really provide that ability in a more efficient way. So let's do a drill down into each of these 2 options. So with the first option being the machine-readable file, CMS outlined specific criteria to really create that file. And what you're going to need to do to create the file is likely going to be to analyze your historical billing data to determine an ideal claim or patient scenario for everything you do. And then based upon those services, make a determination which shoppable items to post. And then you'll need to calculate the negotiated value for every contracted payer and plan. Now, your patient estimation system, your contract management platform, your decision support tools, or possible options for gathering and calculating these values. But if your current tools or vendors can't provide this data easily or accurately, you're really going to need to queue up, in my opinion, the selection process for different tools and really consider budgeting for improved systems and processes as you go into the new year. Because the thing to keep in mind, this is not going to be a one-and-done project. CMS is looking for these rules to be foundational changes, and you're going to need to ensure you've got tools for the 1/1/2021 deliverable date this time next year, but you're also going to need integrated tools for this type of ongoing analysis work as you go on into the future. So there's a minimum requirement of 300 shoppable items, services, or service packages that must be posted. And CMS has provided the same list. They did not change the list of 70 shoppables. And beyond the 70 shoppables that CMS provided, each hospital has the flexibility to determine the remaining 230. CMS also clarified that this list should be common services that patients typically schedule and receive. So in other words, using a list of 230 lab codes that rarely get used may meet the requirement, but it really doesn't meet the intent. The intent is to list your top 300 shoppable services that are truly shopped. So in the next slide, we've got an example file format that CMS provided earlier this week on their Learning Network call. And it outlines sort of how we should be listing with the description, the code, the NDC, the gross charge, the volume, and then you would continue that process with all of your payers as it relates to the negotiated value. So with the machine readable file, we have to remember too that it has to be easily found, easily accessed, without really any restrictions. It's got to be free of charge. You can't have users be required to enter their name, their contact information, PHI information to access the information. It's got to be readily available from your website. And similar to this year's requirement, as you're updating it, which has to be at least annually, you should list the date of the last update, either within the file or associated with the file name. So the stated rationale for this comprehensive machine readable file is really for employers, providers, and programmers to develop better pricing estimation tools so that the data can be more easily integrated for patients to shop for services on a go-forward basis. So based upon industry feedback, CMS also adjusted the final rules, as I mentioned earlier, to now allow for commercial self-service estimation tools to be used to meet the shoppable mandate component. They laid out specific guidelines, the key ones being it needs to be in plain language, it still needs to be the 300 shoppable services, it needs to be the key things that you do, and it needs to be accessible at the time the patient actually runs the estimate tool itself. So CMS specifically noted that they're extremely flexible with how the estimated patient cost is going to be presented to the consumer. They did provide guidelines and some minimum requirements, such as the 300 shoppable items that have to include the minimum 70 CMS provided items, and the estimate must be available real time. It can't be a phone number. It can't be submit a request form. We've got to upgrade the process is really what CMS is encouraging us to do. Just like we don't want to call Walmart or Target or Amazon to purchase something. We don't want to call Delta or American to book a flight. The same way, CMS is just prodding our industry forward. So it's not just a few organizations that are providing these types of tools. but it really does become more of an industry trend and an industry process that everyone's embraced. It's important to also note that CMS specifically called out the fact that with the machine-readable tools, you can now actually capture certain PHI information to generate the estimate itself. With the self-service estimate tools, CMS recognized the need to capture certain patient demographic data, such as insurance eligibility, to be able to incorporate real-time patient benefit information. You're going to have to capture some basic things like the name, the insurance group, the date of birth, the patient's group number, if you will. So CMS did make that exception to the machine-readable format where you cannot require or collect any of that demographic data. With the estimate tool, you do have that particular flexibility, if you will. So here's an example from CMS with how they laid out a particular file or form could look in terms of presenting the information to the patient. Slide 20, this next slide, really has a better example of how an organization has deployed a self-service patient estimate tool. Metro Health is an Epic client, but they recognize the need to integrate an accurate contractual calculation process to really better manage their strategic pricing methodologies, to model unit charge price changes through their actual payer contracts, and really integrate in with a patient estimate tool. Donna Graham recently conducted a webinar with RevCycle Intelligence on their experience with their self-service patient estimate platform. And Brad, after the call, why don't you forward that link to everyone that's on the call today?
Yeah, that's a great idea, Greg. And Donna had some really good insight on their experience. And I think that session would actually provide a really good foundation for anyone that hasn't deployed this type of application but might be interested in doing so going forward.
Yeah, and I think it's also important to note, if you have employed physicians, your estimation process will need to take that into account. Similar to what you see here, this particular radiology example with Metro Health, they do have both professional and employed physicians. So in their estimation process, it's listing out and separating the two components, being the professional and technical component. That's something that CMS was very pointed in your process. If you do have employed physicians, you're going to have to incorporate that into the process on a go-forward basis.
Yeah, thanks, Greg. And we're going to take a brief pause here now that we've been through the details of the final rule. I actually wanted to ask the audience a poll question. So I'll go ahead and get that started before we continue with the presentation. So now that we know what the final rule is and kind of the options for meeting that mandate, the question for the audience is, how does your organization plan on publicly listing shoppable services in order to meet the price transparency final rule? And so CMS has laid out two options, right? So it's a comprehensive machine readable file, or it's a consumer-friendly shoppable service tool similar to the one that Greg just shared, or maybe you haven't decided yet. So we'd just like to get an idea from the audience what their plans are. So I'll go ahead and launch that poll and give everybody a little bit of time here to respond, and then in the meantime, I'll let Greg continue on with how CMS is going to be monitoring and enforcing this rule.
Yeah, so a couple of quick thoughts as it relates to the penalties. So for 2021, CMS has outlined some specific enforcement guidelines The penalties, in our opinion at this point, are not really substantial from a monetary standpoint. The challenge, I think, for most providers is likely going to be more built around from a marketing and a PR standpoint. If you're in a community that really doesn't care about cost and pricing as it relates to healthcare, in other words, there's just not a lot of competition, you may make a different decision than, say, organizations that do experience price or market share pressure from lower cost providers. And I think those organizations are probably going to need to look at this in a little bit different light. I know the penalty is $300 per day. It goes along with any hospital that isn't meeting the mandate would be listed on a CMS web page. CMS, I think, also went through some very specific steps that if you are identified as being out of compliant, there are specific steps that they will be asking for, what your plan is, what steps are you taking to get to a point of being compliant. I think most organizations, if you're moving in the right direction, CMS will be working with everyone. I think the fine is really more for those that just determine, hey, this is not the direction we want to go. And there'll be an appeal process as well that they outline through the administrative law judge process. So, Brad, do we have our poll results before we continue on?
Yeah, we do. I'll go ahead and share those. So the results of the poll, how do you plan to meet the shoppable services portion of the final rule? 60% haven't decided yet, which I don't think is a huge surprise since this is a newer mandate. But those that have decided are leaning more towards presenting a consumer-friendly, shoppable service tool like we saw with Metro Health, about a third of the audience. And then 10% are planning on just posting the machine-readable file. Greg, any feedback on those results?
Yeah, I think it's important just as we start to think about planning and what your steps are going to be in the coming year. I think with most estimation tools, you're probably looking at, depending on your approach and the group you move forward with, you're probably looking at anywhere from a 3 to 6 month implementation timeline. If you plan on a 2 to 3 month service contracting process, it's going to be something that you need to have queued up probably in January or February to be able to get the system deployed and ready and functional at this point in time next year. Similarly, if you are planning on moving forward with the machine readable file format, you're probably going to need to allow a similar time frame for standing up the application. It's just going to take a fair amount of time to go through and pull all your contracts, do all the calculations, all the algorithms. So it's terrific that CMS gave a year, because I think it may end up taking a year for us to get to that point.
Yeah, great point, Greg.
Okay. So with the final rules for providers, CMS also released rules for health plans. And similar to providers, the current draft rules do have a 60-day comment period. Health plans will also have to release and provide machine-readable files for in-network and out-of-network rates. Plus, they will be required to deploy self-service cost estimation tools. So we're encouraging all hospitals to respond during this comment period with their thoughts around what additional information health plans should be disclosing. Hospitals often struggle with authorization, denials, changing payment rules. So obviously, now is the time to make your thoughts known. So if you haven't incorporated, plans to respond to the current health plan comment period, it's definitely something that you should bring up to your pricing transparency team and probably look to incorporate and include some type of communication back to CMS. The core requirement, again, is the mandate is to make the process of both quality and price data more transparent. And obviously, we work with this data all the time, so we know the rules of payment and reimbursement aren't always as clear as we would like for them to be. So if you're struggling with things, again, like denials, authorization, changing payment rules that ultimately end up impacting the patient and how you have to bill the patient, now would be the time to incorporate those items.
Yeah, and as we conclude and start to wrap up here with some final thoughts, Greg, I think it's really important that, we kind of get out of this habit of doing these random acts of price transparency. I know the mandate last year to post your CDM file felt more maybe painful than we would have liked to do, but it's really all moving towards providing relevant information for patients. So it's really important to start thinking about having a strategic plan in place, and really aligning different departments, and really understanding what your outcomes want to be and then what the ideal outcomes are for your patients. So we have kind of a readiness checklist here, if you will, of some things we recommend your organization starts thinking about over the next really 3 to 6 months in order to be ready at the end of 2020 to meet the mandate. So first of all, every hospital needs to have a pricing transparency team. And then related to the shoppable approach, we recommend planning on a 4 to 8 month deployment timeline, depending on other projects you might already have queued up for next year. Allowing 2 to 3 months to do research on vendors is probably an appropriate time frame. And so with that being the case, it's probably time to get started. For that 30% that said that they want to implement a consumer-friendly shoppable service tool, the time to start your vendor search is probably now. Related to strategic pricing, don't lose the opportunity to better model your changes now, now that your prices need to be posted. And then other things to keep in mind are around payer scorecards and prospective contracts. Evaluate your current tools and processes. We're going to need tighter integration around all of these things. We can't afford to have various and random systems that aren't talking to each other and don't integrate and that aren't working together. And then finally, review your website, and this is probably a good area to pull marketing in. Make sure that your website has easy access and a good location for patients to find this new pricing information. Hiding it doesn't help anything, and it doesn't make it easier for patients. So just make sure that that's a strategic conversation that you're having with your web and marketing team.
Yeah, absolutely, Brad. It's important to recognize key processes that operate as organizational silos will need to work together in different ways as we go forward, not just reporting to the same executive, but actually operating in and with an integrated platform. And really an accurate allowable is going to be the connecting component. And that's really where PMMC excels. Payer scorecards, financial reporting must integrate to really understand not just denials and contractual short pays, but how are we collecting with the patient? How do we take that into consideration where we're negotiating new contracts and monitoring actual to projected? And how do we adjust charges and reimbursement as the market, being consumers, payers, advocacy groups, really understand how we compare to others? That's going to be a real key difference as we go forward. And the part that I think everyone will start to recognize and understand, to really win going forward with pricing transparency, we're going to have to adapt. We're going to have to be strategic and think in different ways. And we're also going to have the right tools and processes. So what we outlined today are specific tactical steps, if you will, or tasks that you must do. And to really win going forward with pricing transparency, you're going to have to be more strategic. You're going to have a plan that you work, and you're going to have to be willing to update that plan as you go forward. PMMC can obviously support your organization with both strategic and tactical steps. We're recommending clients in your pricing transparency teams really first define what pricing transparency means to your organization. If you haven't already done that, that should be a real critical step because you have to have a strategy that supports that overall directive so that all related departments should begin aligning from the executive team on down, if you will. And going forward, PMMC can really help clients meet the mandate by helping you create the 2 current outline files. We can also help the organization manage the process going forward with capturing new market data to improve your price position. And we've communicated to CMS as an industry that it is better to really not have competitive pricing data if it's too public, but obviously it's wise. If that's the direction we're all going together, it's wise to really understand and evaluate and leverage this data. We may feel like it may bring and raise prices. Obviously, some of us may say that would be a good problem to have. But it's really going to take analyzing the data to be able to remain status quo, if not improve, because without the tools, you're likely going to fall behind. So finally, really, all sides, I think CMS, providers, payers, have consistently stated what consumers and patients really need is an easy-to-use tool to understand the estimated cost for the patient. And that's an area that we can really help your organization if that's something you're looking at, an integrated platform in the future. Definitely let's schedule a follow-up call. The part that I want to just close with, and we'll provide this slide deck is a follow-up activity, is really touching on the way we need to begin thinking about an integrated approach to analytics around those 4 components and really leveraging the accuracy of the allowable. Our payer scorecards, looking at variances, looking at payer performance, has really got to evolve so that we're not looking at just denials or contractual variances in activity, but we're taking that patient portion piece into account. Because if we really want to drive change with the patient portion, we're going to have to know how and where to best communicate to the patient to collect that amount up front. And in the next slide, provides an example of when we're modeling contracts. And the modeling and the negotiation process is only going to get more detail from an analytical standpoint. We're going to have different tools to really do side-by-side analysis that take into account denial history, underpayment history, and the patient portion piece. And in the next slide, we highlight how you're going to need to really incorporate that patient activity to understand the trends that are occurring, what types of services, which payers are shopping online, what your conversion rate is. And in the next slide, we really highlight, if you will, the way in which your platform operates is going to provide you with the right tools to really get to those service package rates through an application versus having to go through and build all of your billing data to come up with the service packages, to then calculate out those service packages through all the payer contracts. you're going to have a tool that actually does that in an automated way. It's just a different approach. We're going to have to move away from Excel and other tools that we've used in the past and really embrace a different level of technology and platform going forward. Brad, do we want to touch on some of the questions that are out there?
Thanks, Greg. Yeah, thanks, Greg. We had some questions come in from the audience, and if anybody on the call has any questions that they thought of during the session, go ahead and enter that in the questions tab, and we'll take those as they come in. So first question I have for you, Greg, if we do go the commercial patient estimate tool route, do we have to list the detailed charges as part of that?
No, CMS clarified that you can just list the service package, if you will, such as a colonoscopy example. You can just list that as the description, and then you would have the corresponding allowed amount, your negotiated rate for that particular payer and plan, and then you would want to incorporate the patient responsibility so that the patient can truly understand what their cost is. You don't need to provide the detailed charges that would roll up to that particular service package. You obviously could, but it's not necessarily a requirement.
Gotcha, thanks. Next question. AMA has had issues with posting CPTs. Did they make a change?
Yes, I understand. AMA did post on their website that they are going to be modifying their position in that if CPT codes are needed for an organization to comply with federal regulations, then they will be, if you will, waiving that requirement. So AMA has made some concessions in that particular area.
Thanks. And then next question, can we post more than 300 shoppable items?
Yes, the 300 is just the minimum number. Obviously, if you want to list more than 300, you've got the flexibility to do just that.
Another good question here. What's the reason for the minimum and maximum de-identified rate?
I think it's really just to make it easy for the patient or the consumer to quickly see what the high and low negotiated rate is. Obviously, you could scroll across the 60, 80, 200 different payer plan code combinations that you may have. It's really designed to very quickly see what the high and the low would be. Without identifying the specific payer, it's just listing what the high and low is across all of your payer and plans.
That makes sense. And I know we're a couple minutes over, Greg, but we've got some good questions. So if attendees want to stay on the call, they can. And if you need to run to something else, this is being recorded, so you'll be able to catch those questions. But I'll continue here with a few more. If we have an estimate tool, is it okay to get the patient demographic data?
Yes. So CMS did clarify if you're posting the machine readable format, you cannot collect or require the patient to provide that information. But they recognize for really an estimation tool to be able to generate an accurate estimate, there is some basic demographic data that is needed. So they were very specific in calling out the fact that you can collect things like name, date of birth, the payer plan number. That information can be collected because you're going to need that to be able to verify coverage and to gather the patient benefit information, being their copay, coinsurance, deductible, remaining out of pocket, for a more exact estimate, if you will.
Gotcha. Can we just list our top 10 or top 20 contracts?
Unfortunately, CMS has stated several times, there were a number of places, it does need to be all. There were a number of comments with organizations from our industry in the comment period, suggesting they go with the top 10, top 20, top by volume, some volume thresholds. But CMS has consistently said it needs to be all payers and plans that you have a negotiated contractual agreement with.
Sounds good. And another question here from the audience. If we use an estimator tool, does it have to have all payers for the service package?
Yes, it would need to be all payers and all plans that you have a negotiated contract with.
Okay. And then another question here. What if a plan has more than one product type? Can the provider just provide an average of the product types?
No, CMS specifically called out if you have different product types or plans within a payer, you cannot use an average of all of them. It needs to be specific to that payer and plan.
Okay. This one was more specific to the Metro Health example, if you can speak to that. The question was, the Metro Health example did not show the negotiated rate, only the patient responsibility. Would that meet the rule?
It likely will, just based upon CMS's comments thus far with their flexibility around providing the patient with what they need to make a well-informed decision. CMS did clarify that in the commercial estimate tools, you do not need to list the gross charge. You need to really focus on what the patient responsibility is going to be. Obviously, that will be one of the questions that we'll be posing to CMS, and hopefully they will be doing more learning sessions. They'll be publishing, hopefully more than one, frequently asked question document as we go through the year, clarifying those points. But right now, they have very consistently said there will be more flexibility in how the industry responds with those estimate tools, as long as it's meeting the overall goal and intent of providing the consumer with what they need, which is really an understanding of what their responsibility is going to be from an out-of-pocket standpoint.
Okay, thanks. And then I think we'll take one more before we sign off here. If our contract with a Medicare managed care plan or Medicaid managed care plan is to be paid the same as Medicare or Medicaid, is that considered a negotiated rate?
It would be. CMS had noted that you would not have to list, some organizations may choose to, but you will not have to list the Medicare and Medicaid rate. But if you do have commercial Medicare and Medicaid rates, such as Advantage plans, you would need to list those values because you negotiated that component with that particular payer.
Gotcha, that makes sense. Well, if there aren't any other further questions, I think we'll go ahead and wrap up today's session. I want to thank you, Greg, for sharing all the details of the final rule and things that we need to start thinking about for 2020. Just a note for the audience, this session was recorded, and a copy of the slides and the recording will be sent out to all the attendees in the next day. My contact information is on the screen, so is Greg's. If you have any questions or want to continue speaking further about this, feel free to reach out to us. And I'll turn it over to Greg for any final closing thoughts.
Great, thanks, Brad. We certainly have appreciated the questions that have come through in between the webinars over the last 4 or 5 months. As we go into 2020, we're going to continue providing these types of webinar series. Most are going to be somewhere between 30 and 45 minutes. We have reached out to a couple of individuals that we'll be scheduling, and you'll be seeing some correspondence come out from us. One that we are looking to incorporate will be an attorney who has spent a significant amount of time, 25 plus years, negotiating payer contracts with hospitals he's going to be offering up his perspective as it relates to some things that you'll want to take into account as you're renegotiating contracts going forward. The pricing transparency will raise some concerns that you'll just want to make sure are addressed in your contracts. Similarly, we will be incorporating some individuals that have more of a coding background and experience to speak to this particular issue from a coding standpoint. That'll be coming up sometime, both those in Q1. So we're going to continue this based upon the positive feedback that we continue to receive from those that attend the webinars. I do appreciate your time today, and hope everyone has a terrific December holiday.
Thanks again. Bye, everyone.